Hello, everyone. And before we start officially, Kara, I just want to make sure that you and Melody, you're ready. You're going to go first, correct?
We are. I don't see Melody on yet. She is in clinic, so I will be prepared to do it solo if needed.
Okay, and I will start us at 4:01. And then other two presenters, Kristen and Christy, I saw that you were both on here. Thank you. So welcome everyone. I see a lot of people logging on right now and joining, so let's just give a moment. Okay, I will go ahead and begin. Welcome. My name is Rebecca Utt, and this is an event put on by the Consortium for Families and Health Research, CFAHR, at the University of Utah. And it's part two of a two-part series where we're talking about how has the COVID-19 pandemic affected families in our communities. And the one thing that we noticed as a research community is that so many faculty across campus, as this pandemic was unfolding, immediately pivoted their research and began some new research projects. So this two-part series was just an opportunity for us to hear about some of the research that has been created here at the university. And we focused mostly on those, because we are CFAHR, on those projects that have focused on the family's well-being, the family dynamics and relationships. And today, well, last week, we heard from these three presenters that are shown on the screen that really focused on sort of the aspirations, the dynamics within the family, the communication within couples, and how households are managing extra time at the house and housework. And this week, we are focusing more on how has the pandemic been increasing our social isolation? How has this affected the family members that are providing care to those that are perhaps disabled or in need of support? And then also, how has the COVID transmission occurred within families themselves? So without further ado, I would like to introduce to you our three presentations today. And we will go through each presentation fairly quickly. If there are comments or questions that you have for that individual presenter, go ahead and put them in the chat. I will try to facilitate those right after the presentation. And then hopefully we can also save a little bit of time just to have a bit of an open or interactive discussion about how this pandemic has affected every aspect of families in our community. So our three presenters, well, three presentations today are, the first one will come from Dr. Kara Dassel and Dr. Melody Mickens, and they're going to talk about family caregivers as being the unsung heroes and invisible healthcare workers during COVID-19. Our second presenter will be Kristen Cloyes, coming out of the College of Nursing, and she's also going to talk about cancer caregivers and cancer survivors with a specific focus on LGBTQ groups during the pandemic. And then finally, we have Dr. Christy Peruznik from Public Health that is going to talk about her work looking at and documenting the transmission within Utah households. So with that, I will now stop sharing my screen. Kara and Melody, I will turn the time over to you, and you should be able to share from your screen.
Thank you. I don't know that we decided who's going to share. So
I can share, Melody. I got it pulled up.
okay, thank you. Awesome. Thank you.
Can everyone see that?
I can see it. Looks good.
Okay.
So the focus of our project has been capturing the experiences of family caregivers during COVID-19. Just a little bit about our group really quickly. We're a group of interdisciplinary professors, researchers, clinicians, providers, consultants, I think as well, all united by our interest in family caregiving and part of the U of U Family Caregiver Initiative. Can you go to the next slide? So at the beginning of COVID, we all discussed really wanting to get a better understanding of how COVID has affected caregivers' experiences, both in terms of how they're relating to the individual that they're providing care for, how they're taking care of themselves, how they're adjusting their weekly and daily schedule to now accommodate the burden of having to protect themselves and their households from this disease and its transmission. Next slide. So we sought out to accomplish that by creating a web-based survey. It was a purely collaborative venture. The focus of our web-based survey was to collect some quantitative data so we could characterize caregivers. We focused mainly on the Intermountain West, although our sample was predominantly from Utah. And the specific information that we captured included demographics, the type of care provided, relationship to the care recipient, the care recipient's medical conditions, and then any specific changes in caregiving due to COVID. We also looked at the impact of these changes to caregiving on the caregiver. So we had questions about access to resources, PPE, changes in respite care. And then in addition to the quantitative portion, we offered all of our participants the opportunity to engage in a 20 to 30 minute qualitative interview. We had about a third of our sample that did participate in this, and this was a more in-depth look at some specific areas. So if these are some questions that we actually asked as a caregiver: where do you seek emotional support? In what way has caregiving evolved or changed in response to COVID-19 as it continues to affect our community? And then also really looking at end-of-life care and long-term planning and how COVID had affected some decisions and even conversations about this topic within families. We launched our survey from June through July 2020. So that was really before the big surge in Utah, but still when things were fairly fresh and uncertain. Next slide. So just to characterize our participants, we had 96 individuals who completed the survey, and then again, 29 who went on to complete the interviews. 45% of the 96, so all these numbers are based on the 96, were caring for a parent. 72% identified as the primary caregiver. We also asked for individuals who identified as primary and secondary caregivers, because we recognize that in addition to caring for people who are already in their household, like their children, some individuals might also be caring for parents or siblings or other individuals simultaneously. So we were able to capture that. Only 5% of our sample said that they were caring for individuals with COVID-19. So most of their care recipients had pre-existing conditions. 51% had been providing care for a range of 1 to 5 years at the time they completed the survey. And 41% were providing care to individuals with neurological disorders. When we characterized neurological disorders, that included dementia. It also included, I believe, some neurotrauma, so brain injury. I think we had a couple of individuals who also had, well, we did see a fair amount of parents who were caring for children with developmental disorders as well. 53% of our caregivers spent 20 or more hours per week providing care, and then they were predominantly white, female, and age 30 and up. Next slide. So these were the results from our quantitative portion. We'll also talk a little bit more about the qualitative portion. Less than 5% of our caregivers were exposed or directly caring for someone with COVID. I think this is pretty significant because it also suggests that a lot of these caregivers weren't just becoming caregivers. They were taking care of this individual and then also dealing with COVID on top of this. Almost all of them said that their caregiving circumstances had changed. 83% of them reported more caregiving related stress. 77% reported feeling lonely and isolated at least once a week. 65% reported spending significantly more time on caregiving related tasks. And often this was due to a lack of respite care and access to community resources that would have offset some of the need to engage in certain activities of basic daily living, for example. 53% reported that they didn't have adequate support for their own mental and emotional health. What we are seeing is that some individuals had to put those on hold while they were taking care of their family, but also in response to community resources that closed temporarily or reduced access as healthcare systems also tried to figure out how to manage the spread of COVID and still function safely. Next slide. Was this part of our qualitative analysis? Sorry.
No, this is just some examples of the
Oh,
added
okay.
stress.
Yes, okay, so as part of our quantitative portion, we also included open-ended questions. So some of the individuals who probably did not complete our interview also had an opportunity to write in specific examples of how they had been impacted and how their family had been impacted. So the top one each day is emotional and stressful. Maintaining a balanced relationship under the pressures of making informed decisions has become increasingly difficult. Learning new technology to manage routine tasks is new. Watching the impacts of isolation is difficult. Primarily, I have little opportunity to now get away from caregiving to socialize, go out to visit anyone, take mom to any events outside of the home. Mom is not able to have other family for company over, so her mood is much more unstable. She becomes confused and anxious more often. Her incontinence increases and her sleep quality decreases. So in turn, my rest is interrupted more often, very stressful for both of us. So I think both of these quotes really capture our sample's struggle and a lot of what many of us are experiencing as we accommodate to fewer resources, a pandemic that is ever evolving, really trying to seek out some normalcy, but also maintain consistency for a population that when you take away certain services, there's a potential for clinical regression, whether that's cognitive, emotional, functional, or behavioral. Next slide. So we also identified quantitatively some of the greatest challenges that our caregivers experience. As you can see, many of them, almost a fourth of them actually, reported feeling isolated. Close to a fourth reported anxiety about actually getting COVID-19. The loss of respite care was also a major challenge and stressor for individuals. And then, as you can see, even getting basic necessities like groceries, trying to coordinate care, also juggling the needs of another generation, children, in addition to caring for a parent. So we sampled, I think, a fair amount of the sandwich generation, or we were able to capture for some individuals who may have just had separate roles, now a dual role of caregiving, trying to take care of your children while managing your older adult parents. Next slide. And I think, is this where we split and we're going to focus more on the qualitative?
Yes, I will take it from here. Thank you, Melody.
Yeah.
So one of the strengths of our study is there were lots of surveys going around about COVID, but most of them were purely quantitative surveys. So our mixed methods approach gave us a more depth and breadth to what the caregivers were experiencing. So we had 4 different primary research questions we were going into when we designed the study. One was, how has COVID influenced advanced care planning? How has the definition of respite changed during COVID? How has caregiving access to coping resources impacted relationships and social isolation? And then, have patients shown any clinical regression during the pandemic? So as far as advanced care planning goes, and we divided up these questions into different writing teams. And so these teams are in various stages of writing up the results. But for the advanced care planning team, we found that 63% of care recipients had an advance directive prior to COVID-19. However, 19% revealed that they had updated it since the start of the pandemic. So COVID-19 was not sending people back to pulling out their files, talking with their doctor, making any sort of adjustments to their advanced directives. Interestingly, only 33% of caregivers said they had made a contingency plan should they become sick from COVID and be unable to provide care. And then when we coded our qualitative surveys and interviews, we came up with 3 domains under advanced care planning in terms of common responses we saw from our caregivers. So we saw that there was an interruption of care plan. So thinking about advanced care planning, not just in terms of completing an advanced directive, but having conversations about care, maybe moving someone across residential options for care. So interruption of care plans, he was doing a lot of therapy and all that stopped, except for the type that comes over the phone and over the computer. So a lot of people had their healthcare plans shifted to telehealth or canceled altogether or modified. A lot of the caregivers were, again, this is a very overwhelmed group. Caregiving is overwhelming anyways, and then the added stress of COVID that we talked about earlier. So they were not really thinking about the future. They're just focusing on the day-to-day. So one participant said, well, I guess I don't really look too far into the future. At some point, my husband's probably going to need home health care or hospice care, but I'm focusing on the day-to-day. So they're not having those advanced care planning conversations or updating documents. They're just in survival mode. And then navigating without a compass, one participant, when we asked about advanced care planning, said, no, I don't think it's occurred to us to complete an advanced directive. I think we're just hoping for the best possible outcome. So we're seeing that there wasn't a lot of additional guidance or education or support from healthcare providers or community-based aging agencies to encourage advanced care planning in this population. And then another group was looking at respite and how the definition of respite might have changed. And as we all know, during the early days of COVID, especially, a lot of formal services closed. So there's adult day centers, daycares, maybe meals on senior centers, meals on wheels, things like that. So one participant said, the adult daycare facility is unavailable, causing interruption to the work responsibilities and educational commitments. And then another one said, our wonderful hospice caregiver had to stop coming due to COVID, which put me in the position to provide all the care that was needed. So the sudden changes that caregivers are having to adapt to. Travel bans and calls for physical distancing threaten the informal arrangements that caregivers had with out-of-town families and neighbors who used to share the caregiving responsibilities and offer a break to the primary caregiver. But again, a lot of that stopped or is delayed. One participant said, I used to get a little help from other family members due to COVID-19. Most of the family now refuses to come. Another person said, everyone is so wigged out about getting her sick that they just essentially drop food at the door and leave. It's caused a lot more tension. And another example is without these respite breaks, isolation and burden increase. So you can just see that COVID is causing this cascade of events in these caregivers' lives and the care recipients as well. So, and we don't get a break the way we would before. We would have had other people around to support him. Now we've moved to being where we're one of a team of people. Now we're basically it. And the burdens of all that are definitely impacting my husband and I. None of them are doing anything right now. And I totally understand why. I get it, but man, it makes life hard. I do not get any much needed breaks to go out and have mental health days. This used to be my way of regrouping. Caring for someone with dementia is tough, tough, tough when you get no breaks. I just need help. So these support networks are just falling away during COVID. And all that pressure is being placed on primary caregivers. But the silver lining is these caregivers are resilient, and they've revealed many ways that they are getting respite, not in a formal sense, without access to their formal or informal arrangements. So maybe just short breaks of self-care without leaving the house, coming up with creative methods for respite. So this is the basis of an article that this team is working on, where they're redefining respite and offering lessons learned that will hopefully be carried on post-COVID for caregivers. And then Melody is going to talk a little bit about the coping and social relationship findings.
I will fly through this super fast because I'm being mindful of time, but also we are just starting to look into the qualitative data. We are focusing on the psychological aspects of being a caregiver during COVID-19. But really what I wanted to highlight is one area where all of us were really excited is looking at the dyad and social network dynamics. So this idea that COVID has really affected the relationship between the caregiver and the care recipient, and also some of the larger care networks that kind of surrounded the care recipient as well. So one of the quotes that kind of captures this a bit is, "It's changed because my mom is being nice to me. She's really gotten so that she'll tell me what she wants and needs, and then I've surprised her with a few things. It's been such a big deal for her to have some of these surprises. I mean, it literally changes the day." I think we all have come to realize how the little things can make so much of a difference in any day. So this idea of like really appreciating how the care recipient and the caregiver are engaging with each other differently. We're also trying to focus on a resilience aspect here as we look through this data, because many of our caregivers have talked about the positive aspects of COVID in that it's increased and really deepened the relationship quality and time with the care recipient. So more to come from our group.
Great, thank you. And this last research question, it doesn't look like at this point, unless we continue with follow-up surveys, that we have enough data to have a separate paper on this, but it's just fascinating. So I wanted to quickly talk about this finding of clinical regression. A lot of caregivers mentioned that the care recipient had worsened during COVID. Again, another sequela from the COVID cascade. So as this person is a dependent, the amount of time I spend on them has increased markedly. Also, the elimination of typical routines has caused exacerbation of behavioral issues. Then I realized that getting 10 to 15 hours of respite a week was keeping my sanity in check. Going weeks without it or very little required much self-control and mental preparedness to get through the day, week, month. I do believe my spouse's regression, who had Alzheimer's disease, accelerated over these months. It's affected her as well as me. Tough. Lastly, mom is not able to have other family for company over, so her mood is often unstable and confused and anxious more often. This is a quote from before. Again, her incontinence is worse, her sleep is worse. So it's just a cycle. The care recipient symptoms are bad, which adds even more stress on the primary caregiver and their experience. So to wrap it up, where are we going from here? We're in the process of writing up the first 3 research questions into manuscripts. We have talked about maybe doing potential follow-up surveys with those who completed the telephone interviews, just because COVID has, we only captured 2 months of COVID, and it's been an emotional roller coaster of panic in the beginning and then settling in the summer. Things look good. People were letting their guard down, maybe relaxing a little bit. Then the long winter set in. And so there was different challenges along the way. And, even as vaccines roll out, the new normal is probably farther off than we hope. So we're discussing that. And then there is this new group of caregivers that's emerging who weren't caregivers before, but now with COVID-19 symptoms and some people being permanent or long lasting, this new group of caregivers are being thrust into being COVID caregivers and these long haulers of COVID-19 symptoms. What does that caregiving experience look like? So that's another potential avenue to explore. But we will wrap it up there. I don't know if we're doing questions now, Becky.
In the interest of time, we need to get 3 presentations, and we're already at 23 after the hour. So if there are quick questions, please put them in the chat. I will try to get them to the group later. So Melody and Kara, thank you very much for presenting about your very rich research with the caregivers that have been affected by COVID. And Mike, I will get your question and try to wrap that up into a discussion in a little bit. But without further ado, I would like to go over to our next presenter, who's Kristen Cloyes, who's going to talk about cancer and caregiving in the environment of COVID. So Kristen, go ahead.
Great, thank you very much. Can everybody hear me okay? All right, I put way too much into this, so I'm gonna fly through some of it, and you'll have to forgive me. I got very excited. So we became a COVID study. We didn't set out to be a COVID study, but COVID happened in the middle of our study. So we were one of those teams that also pivoted in order to capture some of this information. So we're engaged in a program of research across several different sites and teams. It's the one acronym I've ever invented in my life that's worth anything. It's the SNASI study, Social Networks and Support Interactions. I'll tell you a little bit more about that in a second. And what I'm going to be presenting on is the first two of our pilot studies. We're engaged in a COVID-focused SNASI study right now. But essentially what we do is we take the caregiver and the survivor dyad, and then we situate that dyad within both of their close personal support networks. And then we use that information to pre-populate daily longitudinal surveys that we send participants about the support interactions that they're having every day with the members of their close personal support networks. So this is generating a huge amount of data. And what I'm going to share with you is some serendipitous findings we developed because at our Utah site, for my portion of the study, I was really interested in looking at LGBTQ plus cancer survivors and their caregivers. So that's what I'm going to be talking about today. Just some basic premises of this family of studies that we have. We all know how critical social support is for cancer survivors and their caregivers. We also are learning more and more about how in real life support and caregiving is actually distributed over a range of people and relationships and roles. So it's not just contained within the dyad typically. That the daily interactions are really the social environment where support lives and breathes. That survivorship, cancer, caregiving research up to this point has sort of tended to lack diversity. And some of our models and pet theories are really normed on, they're heteronormative, cisnormative, really more focused on older adults, which can hamstring our ability to understand what's going on with folks that are not in those groups. That understanding dynamic and ongoing processes require more than static measures and cross-sectional designs. So we're trying to work more in that direction. And that to increase the representation of historically underrepresented groups in research like LGBTQ plus participants requires more flexible designs that attend to the intersections between social categories and relationships. That's kind of our manifesto. So you're going to hear a lot of the same things that you just heard from the team that just presented. We do know that COVID has had a tremendous impact on cancer survivors and caregivers in general across the board. There are perceptions of higher risk related to cancer histories, immunosuppression, being immunocompromised. There's been tremendous changes in access to cancer care and formal support. We're still seeing the effects of that. The impacting of social distance on informal support systems. You've also heard about that. Increased caregiver burden, risk for isolation, disruption of support networks and interactions. Those are things that are affecting all of our cancer survivors and caregivers at this point. As I said, because we were focused on LGBTQ plus survivors and caregivers, we got to hear a little bit more about some of the risks that are particularly pernicious for this population. Most of the cancer centers and institutions don't collect orientation or identity data, gender identity data. So it's not something that's systematically tracked. So it's even hard to do things like assess cancer risk, track caregivers, because we just don't collect those data. There are longstanding historical disparities in income and employment and insurance for people in the community. So when you get issues of financial toxicity, we're going to see, I don't even think we know the financial toxicity that's also going to be related to COVID coming down the pike. You're going to put those two things together and layer that over a population that has been historically disadvantaged. And I think we're going to see tremendous effects of that coming down the road. There's longstanding barriers to accessing competent support and care services. We have a lot of anecdotal reports, systematic surveys tracking people's perceptions of being treated with discrimination and bias, and the effects of that often lead to less screening, less engagement with healthcare systems, later stage diagnoses, higher cancer burden, those types of things. And then maybe not particular risks for isolation, but we do tend to see, when we look at social networks of LGBTQ folks, we see a tendency towards more compartmentalization, parts of the network that don't talk to other parts of the network. And then as LGBT folks age, we can see a dwindling of the networks and older support systems. So the purpose of what I'm going to talk about today is to describe the impact of COVID-19, the pandemic, on LGBTQ+ cancer survivors and caregivers' perceptions of access to and adequacy of formal and informal support services, and also what they have to say about unmet needs. This is a secondary data analysis that draws from both interview and focus group data that comes from two different sources. One are dyads who participated in our SNASI pilot study, and another is a community advisory panel, a focus group that we conducted through the CCTS community engagement team. So we have an N of 19 total in this data set contributing these data. These are just a quick look at the folks that participated in our study. You can see our mean age is right about 42, so a little over that YA line. We had quite a range there. We have different orientations represented, different genders represented. Unfortunately, we have a very homogeneous, in terms of racialized categories, very homogeneous sample there, as well as ethnicity. So that's something we're hoping to branch out on and get more representation and later work. We identified, after sifting this information together and doing content analysis, 9 primary areas of concern. And so I'm going to run through those areas. And I have quotes from the participants just sort of illustrating what they have to say about each of these areas. There's a concern about a reversion across the board to less inclusive and less competent care. And I'm not going to read the quotes to you. I'll give you hopefully enough time to read it. If anybody's interested in this, I'm more than happy to share these slides after the presentation. Just hit me up, email me, and I'll send them to you. But I think this idea that when everybody's hair is on fire, cultural competency just goes by the wayside and becomes sort of one more thing. And there's a perception, as the first survivor said, that it's going to sideline everything and set us back a number of years. So that's a concern that people have. There's a concern about a lack of visibility or even aggression back to invisibility that will result from the pandemic. This one participant described having been very active in a patient cancer survivor advocacy group, working with a particular hospital system. And as soon as they started having to make decisions about COVID and COVID-related issues, they shut down that arm of the folks that were informing them. So there's a concern there as well. I could have pulled 10 to 15 really heart-wrenching quotes about the tremendous perception of loss associated with not being able to have your folks, your people with you when you go into your appointments. This is huge for people in the LGBTQ+ community. There's a sense of loss of advocacy. There's a sense of not having that person there who will run interference for you and guard for you if necessary when you're vulnerable, and actually speak out and counteract, potential discrimination or bias that you may encounter in your healthcare encounters. So I would say this was definitely a major theme that we heard from folks when they were telling us about their experiences, both as survivors and as caregivers. Tremendous impact, really hard to overstate this one. Everybody is experiencing reduced or altered communication patterns and interactions across the board. So I don't think this is necessarily particular to folks, but this is definitely something we heard a lot about. Altered sense of community connection, both people talking about their connection to their cancer communities, the people that were their touchstones, the organizations, the events that they participated in, as well as LGBTQ+ communities, loss of public space, loss of shared space, also having an impact on folks. This is also something that was pretty persistent and widespread before the pandemic. It's become, as we've consolidated resources and services, even more of an issue during the pandemic, is this perception for both young adults and LGBTQ+, those are not mutually exclusive groups, of course, but the sense that the formal supports that are being offered aren't really culturally competent, aren't really for them. If you have to go into a focus or a support group and explain your existence or your relationships to people, it's not terribly therapeutic just to bring other people up to speed. So that's also seen as a ongoing issue. And then people talk about sort of becoming more aware both of the ways in which their support systems are very supportive to them and also the gaps that they're experiencing now. So we saw a number of aha moments for people where in both positive and negative, where they're realizing how reliant they are or the gaps that are there in their support systems. And then another silver lining, right? So we always have silver linings. For many people, particularly people, we heard from people in rural states, rural areas that didn't have access unless they traveled into an urban area to support systems. And they're like, I can go on Zoom now. And I can connect into resources that I would have had to, like, as an immunocompromised person, get in a car, drive to, right? So there's a sense that that's opening up. And then I thought this was a super interesting quote. This is from a cancer survivor about that sense of, yes, it's very isolating, but at the same time, now you all know how we've been feeling for quite some time about being isolated, and maybe you can share some of our existential angst now with us. So I thought that was an interesting quote. Some other tantalizing findings, we're still analyzing our dyadic data, our daily interaction data, but some of the things that we think we're seeing from these data that sort of underscore these points, by and large, it's at least in our sample, when we look at the social support networks, that these are egocentric analyses, so they're centered on either the survivor or the caregiver. The networks of the LGBTQ+ participants compared with those who are not, they're more ego-centralized, less dense, and more fragmented. And essentially what that means, I have an actual network here on the screen. The blue is the caregiver, the red is the survivor. And it's almost like, you know, cat's cradle, that thing you do with a string. If you actually pick the caregiver out of this, all the connections between everybody else would essentially fall apart. So if that caregiver is out of the picture, that social support system is really no longer functional. And so that's a problem, right? That's somebody who probably is going to need something packed around them in order to be able to really do a little bit better. Our LGBTQ+ participants on average report fewer daily interactions. They report having more supportive interactions than the folks who are not LGBTQ, and also more interactions they perceive as not as supportive. So we think we see some ambivalence there that we don't see as much of in the non-LGBTQ+ participants. We also see more emotional and less instrumental support being reported. And we see more of a reliance on social media as a way to connect with people and less in-person interactions, even during the pandemic. So these are things that we're seeing in our sample with some of the data that we're collecting now and increasing our sample size. We're hoping to chase these things down a little bit more. Also, interestingly, for regardless of whether you're LGBTQ+ or not, caregivers in both groups report lower relationship satisfaction with their dyadic partner than the cancer survivors. So we do see something with the caregivers there. The caregivers are also less likely to list the survivor as a source of social support in their close personal network than the survivor is. The survivor almost always mentions the caregiver. It's not necessarily vice versa, if that makes any sense. I think the implications are pretty clear. People have unmet support needs. We think there's going to be lingering effects. We really need more research that's more inclusive and representative. That's going to be essential for designing and delivering effective pandemic and post-pandemic support services, even going into the future. Our millennial generation are increasingly identifying as LGBTQ+, and increasing the size of this population. So this is something that's going to stay on the radar. We've got some, like I said, we're continuing to recruit for our 3 IVPR funded study. We're looking for 50 dyads for that study. This is generating a huge amount of data, even though it seems like a small sample size because of the longitudinal daily collection. So we're getting a lot of great information there. If you know anybody who has had cancer within the last 5 years and has a caregiver that might want to participate, definitely send them our way. We'd be super interested in talking to them. And then we have submitted an R01 that's going to be reviewed next month, proposing to compare networks interactions and using some API-ME modeling to look at YA and SGM groups, including YA and SGM groups, and their needs for social support. So that's it. Sorry I went so fast. Happy to share slides. And I look forward to your questions when you have a chance to do that.
Chris, you packed a lot in there and did it very quickly. Thank you for telling us about, you call it the SNAZI study, and the specific data that you were able to get around the COVID-19 pandemic. So there was one question that came in that I think relates to your study as well as the previous one. And this came from Mike Caserta as talking about, well, in your sample, were you able to look at caregivers to persons with COVID? Because I think both the first study as well as this one, we're looking at patients and their family members or caregivers, and we saw very little sort of COVID caregiving itself. So I was just wondering, did you come across any COVID caregivers? Because I know in the first study it was very small.
I can say we didn't. Our folks were super careful not to put, so no, we didn't have anybody who was caring for somebody with COVID.
Yeah. And I think in response, I believe that both Melody and Kara had to hop off of this meeting, but in terms of the first study, we also were not able to look at that, but that I think is a great study, particularly those long hauler COVID patients, and to see how the family is affected by those. And so I think that's a new research area that perhaps some of these teams will report on over the next couple of months or years. So is there any other quick questions to Kristen at this point? Okay. So with that, then I will turn us over to our third presenter, where we really are talking about COVID and COVID transmission within households. And so we're going to shift gears a little bit, but see how COVID really has affected families. And not because COVID has shut everything down, but COVID has spread and has had transmissions within households. So Christy, go ahead.
Working on bringing my shared window back to the front, because of course this never works the way you want it to. Okay, there we go. Okay, friends, are you seeing this? I can't tell.
We still see
Okay.
the small screen. If
Okay.
you want to reshare again.
I am sharing again. But as I am sharing again, I will tell you that what I'm going to be telling you about is our study where we have recruited families to participate in weekly coronavirus surveillance here in Utah. And there's another site in New York City. So here we go. Okay, this study is called CFAHR, which stands for Coronavirus Household Evaluation and Respiratory Testing Study. And Joe Stanford, who's on the call, is my multiple PI for this. We started planning this project last April, and it's a contract mechanism with APT Associates, but the funding ultimately came from CDC. And I'd be happy to talk with anyone about how cool this kind of mechanism is because it's fast. The original plan was that this follow-up was going to last through spring 2021, which was going to be about March. And now we're definitely extended through June. So it'll go to June 30th, and the budget is like $1 million. So what's the big idea? We're enrolling households with at least one person less than age 18 for weekly surveillance. And then ideally, we can study transmission within households, identify asymptomatic infections, hopefully identify risk factors for disease severity. We're studying antibody prevalence by getting 3 to 4 blood draws from people. And there's a sub-study to do whole genome sequencing to identify variants that are associated with both susceptibility to disease and disease severity. So this protocol is being implemented We started out from existing cohorts in 2 locations. At Columbia University, they're working in 2 neighborhoods and initially recruiting from the Mosaic study, which is about influenza. And they've completed enrollment with about 120 households and about 500 people. We started recruiting from the Utah Children's Project. Then we did referrals to volunteers, and we are presently following 4, because more people dropped out since last week, people from about 185 families. And interestingly, our families are as far south as Cedar City and as far north as Logan. So we're covering a good chunk of the state. So for our weekly surveillance, what happens is that each participant collects an anterior nasal swab. So that's just like the front part of your nose. This isn't a stick it up to your brain swab. And then they ship it in a viral transport media with a cold pack by UPS to Marshfield Lab in Wisconsin. And they're doing PCR analysis on all of these. And take a look at the photo, and you see that little blue dot. Since we're working in families and we don't want to identify all this stuff with people's names, each person in the family gets a color. So like everybody's, like all of Becky's would be a blue dot. And we give them a key, a legend for their household, and we gave them a magnet so they could stick the legend to the fridge. So in case they ever forget. If anyone is ill, then they collect extra specimens. So there's another wet swab, there's a dry swab, and then a saliva kit. And again, the color coding is the same for the people. For the blood collection, for adults, we're getting 20 milliliters 3 or 4 times, and we're only getting 5 milliliters from kids. So it's really just a little speck of blood. And this is getting analyzed at CDC so we can look for antibody prevalence and persistence. The genetic sub-study, this is interesting because it was completely optional. We had no compensation, and yet more than 600 out of our 800 and something people consented to do this, which is pretty cool, I think. And it just shows how great it is to do research in Utah. So they spit in this little thing, and then we're sending these to NIH, and they're going to do some genetic magic with it. Okay, so this study involves a lot of stuff. And because of this, I've actually been in the office a lot because we're receiving boxes and boxes of things, and we're shipping out boxes and boxes of things all the time. Some of you may recognize this is our main public health classroom, room 203, which since July has been one of the 4 rooms that I'm using to accomplish this study. We've set up assembly line in here so that I can have the grad students who are working for me accomplish what we need to do, stay apart from each other and, like not trip all over each other. It's good that we're not having in-person class. So I just wanted to show you, we send 8 weeks of supplies to a family at one time. So they get a big box that'll weigh like between 20 and 40 pounds, depending on how many people are in the family, that has a gallon Ziploc bag for each person that we do write their name on. And in there will be 8 weekly kits and an illness kit, all with the same color dot. And then there's mailers and boxes to mail them back in, and ice packs and tape and instructions, all in this big box. We have shipped so much stuff. I am like best friends with the UPS guy, and we haven't had any packages lost, which I think is extraordinary. Okay, so I made these slides last week. So this is as of last week. We started our enrollment in August, and we hit our target of 825 in January. We've created and sent 20,668 specimen collection kits. And if you add up all the stickers that is, it's like 130,000 stickers that we've stuck on. And we've gotten back so far 11,611 samples to the lab. And most of those are weekly samples. But we've had about 275 illness kits sent in during the course of the study. So here's some super secret interim results. Don't anybody call the New York Times, okay? In this, we've had only 147 total positive results. And this represents 48 individuals in 20 families. And 64 of those were from weekly samples, which means that the people were not experiencing symptoms. at the time that they collected that. Because if they were, they would have done an illness sample, okay? So for those asymptomatic, that was 43 individuals in 20 families. And then we've had 81 positive illness results, which is 26 individuals in 14 families. Okay. So just to give you some percentages, because this is what we hear from the health department all the time, among our 825 illness specimens, we've seen 9.8% of them PCR positive for coronavirus. What does that mean? Well, there's still other stuff that makes you sick, okay? Not only COVID-19, even in a pandemic. And among our 10,786 weekly specimens from asymptomatic people, we've seen 1.3% of those that test positive for coronavirus 19 on PCR. So anybody who doesn't believe that asymptomatic infection is a thing, it's a thing, okay? Now this positivity seems pretty low compared to what we've seen reported out of the community. And this is interesting. It makes us think about selection bias from our sample. Participating in our research are probably more likely to follow public health guidelines, because this is a pretty complicated study. Like, you've got to be pretty organized to enroll in this, say that you're going to do weekly surveillance and actually complete the protocol. So probably people who can do this are doing better at guideline adherence. But the other thing is, we're probably not in the right communities. We're only operating in English. And so I'm sure that that is limiting some of our generalizability. I want to get to dynamics within families. And this is a primary question for the study. So we've seen some families where only one person is tested positive. So that would be 0% secondary transmission. And we've seen some families where every person tests positive. But is that 100% secondary transmission, or were they all exposed at the same party? And it's hard to know, honestly, because, okay, there's data on this slide. You don't have to really look too hard at this. I'll show you the important parts in a minute. But for many of our families, we've seen like 3 or 4 of them who are negative 1 week and then positive the following week. So we can't tell who was first, since we're only doing weekly swabbing. We have families that range in size from 2 members to 10 members who are participating in our study. And one thing that's been really interesting to us is that the proportion of people within a family who test positive doesn't seem to be related to the number of people in the household. So I've highlighted here that first green bar, the family of 7 where only one person ever tested positive. It was back in October, so we're pretty sure they're done, right? But then the next bar below that, the yellow one, that was 7 out of 7 right around Thanksgiving. That mom was having a really rough few weeks, right? We've had other families of 3 where 100% positive, and families of 3 with only 1 positive. So this is something that we really want to look at some more. And I'll ask you questions in a minute. So for the 19 families where we've seen a positive result, the average percent of the family that's been positive is 47.6, so it's about half. And interestingly, if an adult was the first one positive, it's lower, 32%. But if a child was the first person positive, it seems higher. These aren't statistically significant, it's really small numbers. And if more than one person tested positive in the first week of any positive, then we tended to see more people in the family positive, about 67%, compared to if it was only one person the first week, about 40%. Again, not statistically significant yet, but we continue to collect data. So I'd really love some input from all of you who think more about families. I'm an epidemiologist. You know, I think about stuff and counting people, not so much talking to them. So we're planning another questionnaire where we can ask some more about family dynamics, because that seems to be important. Like, we know about the number of rooms in the house and, you know, really specific things like that. We're planning to ask about room sharing and bed sharing, because we know that, you know, kids move around and sleep with different people. We want to ask about breastfeeding, because that's one of my favorite things. We're asking about special diets or restricted diets to see if there's any association there. Supplements. One thing that's interesting to me is I plan to ask about the number of siblings that the parents grew up with, because I have this idea that if the mom grew up in a family of 10, she might have a different idea about personal space than a mom who grew up in a smaller family, and that might translate into how they run their family. But we'll see. So I would love it if you think of other things that you think that we should ask, and email me, and we'll try to include it in our questionnaire. I wanted to highlight this is really a team effort. I've had a bunch of public health students working as research assistants for me. The participants are amazing. They're doing a lot of work for us, and we've had a lot of volunteers working on this study, helping us stick stickers on things, helping us pack boxes, helping us put absorbent paper into bags. I mean, all of us have been taking stuff home and like making our kids help, right? And moms and stuff. So I'll come out from the box fort that we built in room 203. I'd love to hear feedback, questions. There's my email again. I'm done.
Christy, thank you. I particularly like this presentation because you remind us of how hard and what the logistics are of collecting your own data. And for some people who have never collected your own data, it's just kind of a humorous presentation to show the boxes, the stickers, the labeling. But this is a really impressive project. And in the chat, one of the comments came is, do you have any sense of what kind of behaviors these families are exhibiting? And does participation in the study, you mentioned this in terms of self-selection, make them more likely to wear masks, perhaps be more aware of? And then also related to that, anytime that a family comes out as positive or doing the illness kits, do you ask them where they believe they may have had an exposure? Are you asking sort of those families of where do you think you were exposed or from COVID?
Okay, so to hit the first question first, I think that yes and no. That being in the study might make people more careful, but I also think that sometimes it makes them less careful, because we've had people call and say, do you have my test result yet? Because I want to go to grandma's house. And we're like, no, this is not how this is supposed to work, right? And in terms of when we talk to people who get a positive result, I mean, they talk back to us, right? And there have been quite a few times when they're like, no, you're kidding. Like, I was just at a wedding, or I just went to a birthday party. And we're like, oh, right? And they are doing weekly questionnaires about behaviors and what's changing, like what's different this week. Somebody went to school, things like that. And so there's going to be a lot of data to analyze along with just the positivity data, for sure.
And then another question came in, and this is also for you, Christy, about, well, I think it's a comment. And it was looking at your difference in rates between if the parent got it first versus a child. And the comment is that younger children oftentimes require support and care from their parents, so it may be harder to actually isolate from households that have young children and completely isolate a parent from them.
Yeah, I totally agree. And I mean, we did like provide extra masks to the families and things, but I mean, it's impossible, right? Like most of you have had little kids. And so I think families do the best that they can, but especially in the times when the kid was the first one, especially if it was a really young child, the parents were like, well, I've probably been exposed to, I'm not gonna lock my 2-year-old away and ignore them. So there was definitely a little bit of fatalism there. But we have seen, I didn't present this data, but the kids under age 10 are 4 times more likely to be asymptomatic than adults when they tested positive. So all that stuff you're hearing about kids more likely to be asymptomatic, I confirm.
Christy, does that work for the young adults as well? Because that's been another kind of demographic that people have thought, the 18 to 30 years or 25 years of age.
Mm-hmm. So in the, we haven't tried to break it out in the adults to compare like the adults to older adults. Okay. And in this study, since we were specifically recruiting families that included kids, I think we are probably underpowered for 18 to 24-year-olds because they were like I mean, yes, there are those families that have kids, but the ones that we're seeing in that age group are more like older adult children that are living at home still, not their own family units. We have seen pretty low positivity among kind of like teenagers, and the other researchers in CDC are like, well, duh, all they do is sit in their rooms all day. So, that's been kind of interesting too.
Mm-hmm. And just a follow-up too, do you have data on chronic illness conditions of family members to understand how chronic illness may make someone more susceptible to transmission?
We have, so for some of our families, the ones who were already part of our Utah Children's Project, we know a lot about them. For the families that were not part of that, we've done a relatively limited medical history. And Cindy, if you have specific ideas about like something we should ask about, hit me, and then we'll try to see what we can include. I mean, in general, these are pretty like young, normal, healthy people.
And in our chat, we said, this is for you, Christy, recommend asking about indoor air movement, air filters, wood burning stove, and those sort of things in the household.
Yep, we'll do.
So are there any other questions or comments about these three presentations overall? And I think that why I really like this session is that we can see that whether it was families that were already managing cancer or chronic illnesses of any sort, how they have been affected by COVID, all the way up to this presentation, just to see how does the family unit transmit COVID itself within that. So at this point, are there any questions or comments just about the dynamics of families and during this era of COVID from anybody in the audience? I would love to hear from you.
Well, I have another question. So on the first presentation, I didn't quite catch who this went out to. Who was the pool of caregivers? It sounded like it was heavy to individuals with Alzheimer's disease, but I couldn't tell from the participants. And the follow-up question to that is, we focus pretty heavily in all of our studies on the focal person who has the illness, but we know that the caregiver probably has an illness as well, which also is made more challenging by COVID. So I don't know if anybody looked at that in any of their studies.
I believe Kara and Melody both had to jump off for either kid family things, and then Melody is in clinic right now. However, a bunch of our team members are on this call, and I will quickly answer. The COVID and caregiving survey was sent out basically through social media. We did contact some people through, say, the Alzheimer's Association, but the sample itself represents families that are taking care of children with autism all the way up to family members that are caring for somebody with dementia. In that particular survey, and I'll flip this over to you, Kristen, we did not ask about the caregiver's other conditions that they may be managing. We just identified if you are a caregiver of somebody, and we only sort of focused on one, not the network of care partners within the family itself. And Kristen, I don't know if that question also, if you want to talk about sort of your sample of caregivers.
So for the studies that we have, that we're still recruiting for now, and the one that we planned, we're asking about caregiver chronic conditions. We also collect psychometrics on the caregivers. So essentially any measure we use on the cancer survivor, we also use on the caregivers aside from the cancer history. But it is the case that often our caregivers also have cancer histories. And we saw that at least 2 instances of that in the smaller pilot that we did, in which case it really makes it very difficult to navigate when both people are sort of thinking about who is most vulnerable between us, right? So who's going to be the person that basically puts themselves on the line for the other folks. I have 2 of my team members here, Kelly and Sarah. Can you Can you remind me, I think we actually do ask whether the caregiver has a chronic illness in the pilot data. I'm trying to remember the first study. You guys remember?
I don't recall.
Okay. There's a huge amount of data.
Yes. And Kristen, your study was existing, and then you just had this little add-on to say what's happening in terms of COVID. Is that correct?
Yes. Yeah. So we were running both at Moffitt Cancer Center in Tampa and here. And Moffitt had wrapped their all of their data collection, and we were about halfway through when the pandemic really hit in Utah. And but we actually added a COVID arm after the fact. I went back and recontacted folks, and so about half of our participants, it was just sort of part of the process for them, and the rest of them, we went back and asked them how the pandemics particularly had affected them in the meantime. So it was a serendipitous way to be able to collect that information.
And Sonia, you asked, have we tracked people over time to see how closure of services like adult day centers, how that has affected people? And the answer is no. And I think that what most of these COVID projects that we've heard about 2 weeks ago and this week is that people pivoted really quickly and tried to get these surveys out and tried to create something new. And we did these in the summer. And I don't think many of us realized how long COVID is going to keep affecting us. And one of the things that we now are thinking about, and Kristen, I think you have an existing cohort, and maybe even Christy, as you think about your studies and several of the studies that we saw last week, it would be great to go back to some of these participants and look at, as we've all become even more weary and tired of COVID restrictions, have some services opened up to support these families? Has transmission changed? Has the stress, the communication, all the things that we've been talking about changed? And so I think a lot of the studies would now like to say, okay, if we had a little bit more time, how would we design our studies in a different way to still capture some of what's been happening with COVID? And I think so many of us that use, say, health records and other administrative records, there's always going to be a blip in our data for 2020 and 2021 about what it is that we typically measure and what are the trends that we're seeing. And so I think that the pandemic will continue to be our research playground for a while. And now we sort of have to catch up our methods and our measures, which we sometimes threw out there really quickly. And I think that's one of the points that a lot of our research studies have seen over the past, that we've seen in both of these sessions.
We're pretty excited about the fact that we've had people who are interested in participating in subsequent phases of our study. So we're going to have at least a subset of folks for the first pilot when we did the longitudinal daily interaction data collection. That was over a 2-week span. The second pilot, it's over a 3-month span. So we assess social network at baseline, and then we ping them for a week and collect their daily interaction data. They have 3 weeks off, 2 weeks. I'm trying to remember which protocol we're using now. And then Kelly?
It's 7 days, 3 weeks off, 7 days.
3 weeks off, 7 days. So we're collecting the data over a pattern like that. And then if those folks go on, if we do get funded and those folks go on into the second study, we'll be able to do that again. And so not only have repeated measures on their networks, but also have these daily interaction patterns over time. And it's going to be probably a small number of dyads we have that for, but enough that we're excited about it.
My biggest advice to any of you that are on this call, that if you collect any data, make sure you put on your data collection instruments, are you willing to be recontacted at a later date? Because that's where some of us have been able to pivot so quickly or go back to these people, because from an IRB perspective, we are able to recontact those individuals. So lesson learned, I don't know if there are any students on here or even any other seasoned researchers. That's critically important for us to do this kind of work and the type of follow-up that we now want to ask on these research questions. Okay, any other comments or questions from this team?
I was just going to say that, so the study that we're doing, despite the fact that it's a complicated protocol, it all came together really fast. I mean, the protocol development between CDC and APT and Columbia and us was done really in May and June. We got IRB approval in July, and then we started implementing, and really quickly realized that some of the measures were just not going to work, and questions that made perfect sense to the people in Atlanta didn't make sense to the people here. And we would say, oh, participants want to answer about their kids going to sports practice, right? And the people in New York are like, what do you mean sports practice? And we're like, yeah, sports practice. And so we've really had to try to adapt and understand what the conditions are, and have way more options for things that we thought that we needed. And in the end, it's all going to get collapsed into categories, but the participants were feeling upset that they didn't see their experience reflected in the questions. And so then it was a really nice reminder about, it would have been good for us to have more participant type stakeholders involved early on. We're there, we're parents, we're people, but my perspective is different than what other people's might have been. And that was missing, and it made more work for us in the end.
But it's also interesting, Christy, because the phenomenon itself changed so rapidly as well, right? You rarely see something happen on a month-to-month or week-to-week basis, and you're getting all this public health information too. So the whole thing is quick. It's pretty interesting. And I've seen Christy on multiple meetings, and she's always packing boxes whenever I'm on with her. So
it's true. Anytime that I'm at the office, I'm like sticking stickers or something, because there's just too much. There's too much to do to not have everybody all hands on deck. And I think I would add to that part about always ask for recontact, is develop and keep a good relationship with your contact at the IRB. Because there's no way, I'm serving as the single IRB for this study, and to push through 15 amendments is, the fastest one got approved in less than an hour, but it would have held us up, so it's good. Thanks, guys. Email me.
okay.
Yes, this is a great set of presentations. I've really enjoyed part 1 panel 2 weeks ago, as well as this one, just to learn about how families are coping with COVID. So before we tune off, Cindy, I want to turn it over to you. Do you have any announcements from CFAHR overall?
Yeah, so a couple things. One is, you should have got an announcement. I think it was last week. We are holding our first ever student and trainee symposium. We're doing this in sort of a lightning talk-like format. So please nominate or nudge trainees. And for those of you who are trainees, please submit it. There's actually money involved, so it's not just one of those, just another symposium. You can actually get a prize. So that's great, but we'd love to hear from our trainees. And if there's more interest than one session can allow, we're going to do a second session. So don't be shy. And this is a great opportunity for trainees to get really wide coverage. And that date is on March 25th. So 4 to 5, and you probably have that already as a hold on your calendars as well. And then we will be even this week announcing another pilot round of grants. We are very interested in doing some of these innovation grants that we funded last time to try to provide some more of the infrastructure for CFAHR and even multiple PI grants, the kind of thing that Becky and Lee Ellington have done, and Deborah Scammon with the Caregiver Initiative is a great example of how a sort of a bigger unit can move forward. And then there'll be some also pilot projects, as well as some graduate student projects as well. So be looking for that. They're due March 15th, I believe it is. We thought we'd give a little bit of time. So I know one of the things that Becky and I have talked a lot about, and I will likely be sending you an email in the next couple of days to see if some of you are interested in, is what are the opportunities for us to have synergies across studies where we maybe had a few smaller number of questions that was in a number of our studies to begin to ask some of the bigger questions. And I know Joe has been talking a lot about this throughout the years on CFAHR Exec Committee is what is the opportunity to really leverage a lot of our different data sets on this thing. So, you know, Austin can, I don't know if Austin's still here. Austin can help us organize meetings if you have a group that you want to pull together quickly for these kinds of things. But I think, you know, there's lots of questions that could be asked across data sets by just putting in a small number of items, potentially, or getting access to other data. So those are the kinds of things that we're really interested in funding on this round. So that's all I have, Becky.
I think that's it. Thank you all for tuning in, and we will see you at some event. Do encourage your students, which will be our next CFAHR event for the students.
Great. Thank you all. Great presentations.
Thank you to our presenters.